Something to remember is, as radiologists, we are really not taught about 4 or 5 stages or the 4 stages of chronic pancreatitis. But if you look at many of the clinical, or if you talk to gastroenterologists, many of the cases actually present with chronic abdominal pain, no imaging findings. That's the early phase of relapsing pancreatitis. So don't worry if a patient is coming with chronic pain to you again and again, multiple episodes, remitting, relapsing, coming over a couple of years, and the pancreas is bang normal on your CT. It can be bang normal on your CT, but if you do an EUS or you do an ERCP, you may see subtle ductal irregularity, subtle wall thickening on the EUS, subtle periductal changes. Those are all your features of an early chronic or a relapsing pancreatitis. So you can have an imaging negative, but you can EUS positive. So that is the early phase of relapsing pancreatitis. Once you go into the chronic pancs with the early or the late phase or the advanced phase, that's when you start seeing the imaging correlate of glandular atrophy. Now, what are the components you actually try to look for? These are the things which I report generally. When I look at the gland, I look for volume, morphology, lobulations, clefting, and signal intensity on MR. I look whether if there is a ductal dilatation, is it an obstructive ductal dilatation or a non-obstructive ductal dilatation? I look at the duct morphology, whether it's focal or diffuse dilatation. Is there side branch dilatation in isolation or in combination? If there's isolated side branch or a duct dilatation, I have to look for an IPPMT and so on and so forth. Whether there are intraductal pathologies like protein plugs, mucins, stones, look for ductal variants, and of course, look for the duodenal wall where you tend to get the